Good morning. This is Debbie Hart, the President and CEO of BioNJ. I'd like to thank you all for joining us for our webinar today on the value of medical innovation in the age of COVID-19, ensuring future cures and protecting patient access. To everyone on today's webinar, I hope you and your colleagues and your families are staying safe and well. We're delighted to have a very knowledgeable group of experts with us this morning for this important and timely program. As the Life Sciences Trade Association for New Jersey, BioNJ is dedicated to helping our members help patients and ensuring that patients have access to the medicines they need when they need them. Before we get started, I'd like to thank BioNJ's market maker and preferred level members who are making our business unusual webinar series in the age of COVID-19 possible. A heartfelt thank you to our Value of Medical Innovation Committee and our supporters for their continued support and guidance. I'd like to share just a few housekeeping items before we move into the program. So this is a listen-only webinar. We encourage you to submit your questions via the dialog box on your computer screen. We have more than 100 folks on the line today, and we'll do our best to get to as many of your questions as possible at the end of the presentations. If we don't get to your question, we will make sure to follow up with you after the webinar. Also, there will be a recording of this webinar on the BioNJ website with the slides beginning tomorrow at bionj.org. So at BioNJ, part of our job is to share educational tools and programs to empower our members, legislators, policymakers, and also patient organizations as you have conversations on the value of medical innovation, the importance of patient access, and the true cost and affordability of life-saving medicines. Today is just such a conversation. New Jersey's innovative life sciences industry develops groundbreaking treatments and cures that patients everywhere depend on. In fact, in 2019, 50% of all new FDA drug approvals came from a company with a footprint in New Jersey. And now in the era of COVID-19, Garden State companies are doing their part in research on antivirals, treatments, and vaccines on this devastating virus impacting the world. In fact, there are more than 50 programs by New Jersey companies working on this brand new disease. Just as importantly, as you can see on this slide, medical innovation in New Jersey also supports a healthy New Jersey economy with more than 430,000 jobs and an economic impact of $47.5 billion with a B. But a threat is looming. Patients and even innovation itself may be endangered by one-size-fits-all approaches to drug value assessment, such as those advocated by the Institute for Clinical and Economic Review, better known as ICER. ICER is a Boston-based research group that uses a controversial method to determine the value of drugs. And as we'll hear, there are numerous concerns on this methodology. Simply put, patients need access to new therapies and medicines, and life sciences companies need to be able to invest in future medical innovation. These need not be mutually exclusive. The medical innovations being developed by our industry are dramatically improving the way healthcare is delivered by helping patients live longer, healthier lives and reducing costly hospitalizations, doctor visits, and invasive medical procedures. There are so many examples, so just a few very briefly. Today, 83% of children with cancer now survive compared to 58% in 1970. Hepatitis C, once an incurable disease, now has cure rates above 90%, developed by a New Jersey biotechnology company. HIV/AIDS, once a death sentence, is now a chronic medical condition. We believe that we need to work together to ensure that controversial value frameworks such as ICER's are not used to limit access to these therapies, medicines, and cures. Luckily, our experts today will share more about ICER and provide statistics and insights on how we can protect patients and innovation. We're hoping for everyone to leave with news you can use. So once we've heard from all of our panelists, we'll open it up to questions from the audience. And again, you can enter your questions in the dialog box and we will answer them at the end of the program. So moving into the program, our first presenter is the visiting fellow in life sciences at Pioneer Institute, a Boston-based think tank. At Pioneer, he writes about public policy issues impacting the life sciences industry, with a particular emphasis on the pharmaceutical industry. He has 25 years of experience in government and in corporate roles, and spent 10 years at Pfizer as Vice President of Public Affairs and Policy. Here to give us a deeper overview of ICER's methodology and its limitations, I would like to welcome Dr. Bill Smith. Bill, over to you.
Thank you very much, Debbie, and thanks to Randy and the others at Bio New Jersey for inviting me today. I'm going to try to give a very common sense understanding of what the ICER methodology is and what the problems are with it. As Debbie indicated, ICER is an institute in Boston that wants to be the cost effectiveness benchmark for payers in the United States. They want to set the prices for therapies that are coming out of biopharmaceutical labs. And they do that in the way that many of the similar institutes in Europe, where there are socialized healthcare systems, do it. They use a standard called the Quality Adjusted Life Year methodology. And basically, in simple terms, Quality Adjusted Life Years is a combined score to rate therapies based on the ability of a therapy to extend life and to improve life. So drugs that can extend life longer and improve life better are going to get higher ratings. Now, people might think, well, this is common sense. Why wouldn't you rate drugs this way? I view the quality as I view kind of communism, where in the abstract, it sounds great. It gets kind of messy in the implementation. So let me sort of explain why, particularly with two vulnerable populations. If you look at older Americans, say that, let's just use a hypothetical anecdote. You have two patients. One's named Captain and one's named Tennille. And Captain is a 65-year-old man who'd like to live to 80. Unfortunately, he has a condition where his prognosis has him not living much longer. And he needs a therapy if he's going to get to 80 and spend time with his grandchildren. Tennille is 30 years old and has a different condition, but the same prognosis, not going to live well into her, into her 30s. They both need some kind of a therapy that's going to allow them to live longer. Fortunately, biotech companies come up with some therapies. The therapy for the Captain is going to get him 15 more years of life. He's going to live till 80. He'll see his grandchildren grow up. Another company develops another therapy for Tennille, and she's going to live to 80. She's going to have a full life, a career, maybe a family. And so there's good news all around. But under the quality methodology, of course, the Captain's drug is going to be rated as less valuable than the drug for Tennille, because Tennille's therapy gets her 50 more years. The Captain's therapy only gets him 15 more years. So ICER is going to advise payers to rate the Captain's drug as less valuable than Tennille's. And if I were the Captain, I would kind of resent that. I mean, I want to live to 80 as much as Tennille does. So there's a problem with this longevity standard, and it gets even worse when you consider things like palliative care, where you're not extending the life, but you may be improving the quality of life of an older person in their final days. And in fact, the health economists in Europe call it the palliative care problem for older Americans. Sue Peshin is much more articulate about this. Is going to go into some of the details and the problems with the quality standard for older Americans. So I'll just leave it at that. But let's look at another vulnerable population, people living with disabilities. And let's, again, two hypothetical patients, Bob and Carol. Bob and Carol, both in their 40s, they don't have a great quality of life because they don't have great mobility. They have two different conditions, but both of them are sort of limited to a wheelchair or a walker, and their prognosis for living long is not great. Two companies come along and invent therapies for both Bob and Carol. Bob's therapy actually gets him mobile again. He can walk, he can play golf, and he's going to live into his 80s. Carol, on the other hand, gets a therapy developed for her condition that gets her into her 80s, but doesn't get her mobility again. She still is living with less quality of life than Bob is going to have. So, of course, under the quality methodology, Carol's medication is going to be rated as less valuable than Bob's. But Carol's going to say, well, wait a minute. It's important that I live till 80. Even though I may not have the same quality of life as Bob, the medicine is going to be as valuable to me as it is to Bob. And if you know people living with disabilities, and I've had some relatives who had, improvements in therapies are going to be incremental. They're never going to get to 100% of quality of life with many of these medications. They're going to have small improvements. And therefore, medications for those living with disabilities are never going to be rated as highly as those medications for patients living without disabilities. And this is a problem, and many in the disability community feel this is discriminatory against people living with disabilities. And some people even say it's a violation of the Americans with Disabilities Act, because they're always going to get lower ratings for their therapies. So next slide, please. But this this webinar is about innovation. So I want to talk a little bit about my major concern with the quality and the ICER methodology when it comes to biomedical innovation. What's happening in the biopharmaceutical industry, as many people know on this call, is the innovation is happening with orphan drugs. In the 60s and 70s, the industry wasn't inventing any drugs for rare diseases. In 1983, they passed the Orphan Drug Act. That started to improve the number of approvals for disease drugs. And then the science started to improve with gene therapy and other things. And then there's an explosion recently in the number of approvals for orphan drugs. Over the last couple of years, more than half the FDA approval for drugs in the rare disease space. So this is where the innovation is happening. And unfortunately, the ICER quality methodology is not well suited to rating rare disease drugs. And that's because the rare disease drug business model is different than the business model for other drugs. And that's for one simple reason. Once you get the drug approved, you spend a great deal on R&D for the drug, but you have very few customers. So by nature, the prices are going to be much higher for rare disease drugs than they are going to be for a hypertension drug that you can sell to 50 million patients, for example. And the ICER thresholds to rate rare disease drugs are quite low. You can see on the slide that one of the thresholds they use, and this isn't the only one, if a drug gets a good quality score and is less than $50,000, it's considered a high value drug. If it gets a good quality score and it's priced between $50,000 and $175,000, it gets an intermediate value. And if it's priced more than $175,000, it's rated as a low value by ICER. Now, this is quite problematic because, of course, many of these gene therapies are not going to conform to these thresholds at all. They're going to have 4,000 or 5,000, and they're going to be more expensive than that. And so, in my view, this is not well-suited methodology for rating rare disease drugs. And in fact, there's some evidence that ICER's methodology has a bias against them. There was a study in Health Affairs published in 2018 where they looked at all the ICER reviews for rare disease drugs between 2014 and 2018, and what they discovered is none, meaning zero, were rated as high value therapies, even though they were quite innovative and they were for terrible and rare diseases. So some of you out there may be sympathetic to this viewpoint, but may also wonder, well, how can we afford $1 million gene therapy? How can the system afford a $500,000 cell therapy or a $250,000 oncology drug for rare form of cancers? The answer is, and this may be counterintuitive to you, but the answer is we can very well afford it, quite easily actually. And the reason for that is that many branded drugs that were quite expensive, that were costing the healthcare system billions of dollars, have gone off patent and are providing enormous savings. The drug that paid my salary at Pfizer was Lipitor. It's the highest selling drug in the history of the industry, $95 billion in sales. It was about $3 to $4 a pill when it was a branded drug. And I talked to an insurance executive a little while ago who told me that the price of Lipitor for him and his plan dropped from $4 a pill to 4 cents a pill when it went generic. So what's happening is commonly prescribed branded drugs that are costing the system billions of dollars, or had been, Nexium, Lipitor, you can go down the list, are providing enormous bottom line savings to payers. The number in 2019, by one study, was 26 billion in savings were being provided by generics. And over the next 5 years, there'll be 95 billion in savings because of generics. And so despite the fact that there are large numbers of expensive rare disease drugs entering the marketplace, drug prices and drug costs, and you don't read this much in the media, but drug prices and drug costs are relatively flat. They're almost 1% or less. So one study said that the CPI, the average price for pharmaceutical products, had dropped 0.7% over the last year. So these new expensive therapies, because they're for a small number of patients, are actually affordable for the foreseeable future. It's hard to predict 10 years out what might happen if we have many orphan drugs approved, but nonetheless, these drugs, the very good news is, particularly for rare disease patients, is these drugs are affordable. And my only public policy advice in this space would be something's got to be done about out-of-pocket costs for patients who have rare diseases, because those are growing at exponential rates, even though drug costs are not growing at exponential rates. So let me just close with the next slide. And this involves a recent ICER review on remdesivir, which of course is Gilead's drug, and it's the one drug that's actually shown some efficacy against COVID. And I was quite disappointed that ICER chose to do a cost effectiveness review so quickly. There are many, many trials going on for remdesivir around the world. The vast majority of those trials have not reported. ICER nonetheless went forward with a cost effectiveness review on remdesivir based on media reports about the data of one trial. The data in that trial hadn't been peer reviewed and published yet, but ICER went ahead with the review anyway. And ICER's, one of the assumptions that they had in that trial was that there was the R&D cost. The R&D cost for remdesivir was zero. Now, I know for a fact that's not true. We had a family friend who was in a trial for remdesivir because he had COVID. He was a 25-year-old, and the trial's still blinded, but he did survive. So we don't know whether the drug worked or not for him, but he did survive. And the cost of that trial was quite expensive. It was an academic medical center. So I know for a fact that the cost of R&D for remdesivir are not zero. And again, they did the trial based on very, very limited data, and with much more data promised in the future. And so I think that this is an example that shows that ICER has a certain bias against innovation and is trying more than anything to limit innovation and limit what payers have to pay for innovation. And this was a terrible mistake, I think, in given that this drug was the one drug that showed effectiveness in the pandemic. So with that, I'll turn it back. Thank you.
Thanks so much, Bill. And just to have a real world example like that is just so helpful. Thank you again, appreciate it. And our next panelist is the co-founder and executive director of Patients Rising, an organization that helps patients find their voice and become outspoken advocates for their health care. She manages all of the day-to-day operations for the organization and is the visionary behind all of Patients Rising's programs, including Patients Rising University, which is an educational component, Patients Rising Concierge, which provides support, and the Institute for Patient Access and Affordability, which provides research, as well as the policy and advocacy work of Patients Rising Now. And she's with us today. She has an established track record of building coalitions with patients, caregivers, and medical professionals. We're happy to welcome our friend, Terry Wilcox. Terry, please.
Thank you very much. It's great to be here today and to share with you sort of the patient voice on this panel. You heard a lot of the scientific around the quality and other things from Bill, and you'll hear a lot more on the quality and ICER from our next speaker. But I would like to really focus on how we can unite for the patient. And as we look ahead at the post-COVID-19 world, there is so much to consider. The amount of medical innovation happening on behalf of COVID-19 brings patients, and with that, the entire nation, great hope. And the importance of medical innovation has never had a greater stage in my lifetime, and the patients we talk to really do get that. Now, Patients Rising was formed to stand up for patients, to advocate for their rights, to fight for the treatment, equipment, and services they need and deserve, and to tell the truth about healthcare. And the most important line in what I just said is to tell the truth about healthcare. And the truth we should be focusing on is the patient's truth. And as the leader of an organization that provides support, education, resources, and advocacy training for patients across the spectrum of diseases and age groups, we see and hear firsthand why any type of sanctioned uniform framework would take us in a direction we do not want to go. There is already a struggle for many patients to access the services and treatments they need, and to be honest, it's not always clear what methodology a state or insurance company is using. And states, as we all know, differ widely in what they will and won't cover. There is no alignment on behalf of the patient between the federal and state government. They have no alignment between insurance companies, employers, or agencies authorizing care. And because of that uncertainty on the access side of the equation, we, as industry and advocates and patients, must unite to help shape what that looks like. And here's what we know it does not look like. It does not look like a uniform. There is no uniform one puts on when they become a patient. They often spend years finding not only the right treatment, but the right doctor for them. Patients come in all ages, diagnosis, disabilities, and abilities, and any one-size-fits-all approach or utility of any kind is shortchanging the patient and the doctor-patient relationship. And we must unite in standing against it. Next slide, please. Yes, patients are counting on us. And patients are counting on us to help them get this right. Educating and activating the patients and caregivers themselves to raise their voices is the only thing that will bring about lasting change. We talk to patients every day who struggle for not just months, not just a few weeks or a few visits to the doctor, but years to get the proper diagnosis and treatment. Many will finally get a diagnosis and find out there is no approved treatment for them, or perhaps no treatment at all for them. Being a patient with a chronic or life-threatening illness of any kind is exhausting, and we need patients and caregivers to rise up with their voices. And when they dare to do that, they are counting on us to unify behind those voices with not only industry innovation, but unified policies and actions that will help make their journey to accessing and affording those treatments and care less cumbersome. Next slide, please. Yes, as we all know, healthcare, it is personal. And in the age of personalized medicine, we heard from Bill why the QALY is an impersonal and discriminatory measurement. Patients we talk to get that if you explain it to them. The average person has no idea who ICER is or what they do, but when you explain to a patient what it is they are doing, they get it. And for many patients, it makes them angry. I talk to patients and advocates every day about it. And we have been educating patients on ICER and the QALY since 2016. And our evolution as an organization has brought us to form most recently, and crazily enough, we launched it the same week that the country went into shutdown, the Institute for Patient Access and Affordability. And we work with a health economist and ICER critic, Dr. Paul Langley. And in his view, the reason the impersonal value assessment framework like ICER fails patients is because it does not meet scientific standards, criteria for credibility, evaluation, and replication. And I can go into more on his scientific analysis here, but that is not my wheelhouse, and I'm not going to do that. But for those of you that are interested, I recommend visiting the IPAA website, accessandaffordability.org, and reading some of his work in the Innovations in Pharmacy Journal. And just to touch on it a little bit, though, in Paul's opinion, we have wasted 30 years in health technology assessment, not only in rare and chronic diseases, but in other disease states. Rather than committing health technology assessment to real-world evidence, the focus has been on constructing imaginary worlds in the belief that evidence is created and not discovered. And for ICER, the voice of the patient is irrelevant. They give lip service to it, and even if it is considered, it is a footnote. It is often a footnote. They'll say, oh, well, we read this and we'll include this analysis here, but it's not really factoring into what they are reporting, and it weighs very little in the ultimate outcome. Disease-specific quality of life claims are generally ignored or created as a footnote. Attempting to capture these would demonstrate how barren and unrewarding the current standards for patients are. Perhaps we could reaffirm commitment to real world and not imaginary claims. To move forward for the benefit of patients we all represent, the focus must be on target populations and disease states. And rather than trying to apply a generic manifest score, we must abandon this in favor of a disease-specific measure of quality of life to complement disease-specific clinical measures. The proposed solution is for disease-specific instruments that evaluate the extent to which the needs of pediatric patients, adult patients, and caregivers are met or improved from the introduction of new therapies. We should not be interested in non-evaluable claims. Yes, healthcare is personal, and we need to make evaluating it equally as personal. Next slide, please. When we engage together, that is, patients, industry, patient advocates, patients win. ICER and any framework like it has real limitations, which all of the speakers today are highlighting to various degrees. And we must engage and come together where we can as much as possible. The more we are aligned, the better it is for the patient. We know every company has a different approach and internal mindset for how they engage with the various frameworks, including ICER. But the bottom line is uniform frameworks are wrong for patients, and we must unite behind measurements that lift patients up. And by engaging together to do that, these patients will win. Next slide, please. One thing we should be focusing on is setting collective goals. And one of our current goals is to see quality bands in every state, like the one Governor Stitt just signed into law in Oklahoma. Now, Patients Rising did not work directly on this. I do believe our next speaker did. But it is so important. We've supported it, and we have many patients in Oklahoma. We had letters written to Governor Stitt a couple days before he signed it from some of the patients that we work with. But one of the most important parts of this, and I actually am doing this again on our podcast on Friday, but I want to read to you from this bill as it says everything about what we should be fighting for as an industry, advocates, and patients. And the Sooner State has paved the way for the nation. The legislature finds and declares that physical and mental disabilities, age, or chronic illness should in no way diminish a person's right to life, human dignity, and equal access to medical care. Historically, persons with disabilities, advanced age, or chronic illness have faced discrimination in the healthcare system, including the denial of access to life-sustaining care. Such discrimination is inconsistent with our society's commitment to human dignity and the full inclusion of persons with disabilities throughout society. Such discrimination is now legally prohibited. An agency shall be prohibited from developing or employing a dollars per quality adjusted life year or similar measure that discounts the value of a life because of an individual's disability, including age or chronic illness, as a threshold to establish what type of healthcare cost is effective or recommended. An agency shall be prohibited from utilizing such adjusted life year or similar measure as a threshold to determine coverage, reimbursement, incentive programs, or utilization management decisions, whether it comes from within the agency or from any third party. Setting goals that promote patient access and affordability should be our collective goal. Next slide. Let us engage rigorously, yes, across disease states and the industry. One of the issues in talking to groups, in engaging with groups like ICER, is it's fragmented. Disease-specific groups are engaged when they are being reviewed, but not when their fellow patients are being reviewed. Most organizations don't have the bandwidth. More rigorous engagement is required from the disease-specific leader on any review, but bringing everyone to the table to support patient needs is paramount for the universal understanding of payers and government, regulators, and legislators. COVID-19's focus on innovation for the nation is our moment to bring the patient voice to the forefront, and we must unite across industries and disease states to do just that. Next slide, please. And in closing, we must be collective in our approach. to advocacy. We must be rigorous, or industry must be rigorous in the obvious scientific data needed to create these treatments and for patients. And if you want to hear a little bit more about this, just as a brief plug, I am on a panel, an on-demand panel starting next week with the BIO conference called Get Engaged, How to Talk to ICER and Anyone Else Forming Opinions About Your Care Coverage. And on that panel, I have with me two rare disease advocate moms, as well as Paul Langley, who I just spoke about. You can obviously look that up. And final slide, please. And this is for those of you who don't know anything about Patients Rising. We are at patientsrising.org. We can be found at Patients Rising on Twitter and Facebook. And if anyone has any further questions for me offline, you can reach me at terry@patientsrising.org. Thank you very much.
Thank you so much, Terry. That's just terrific. And kudos on your efforts to educate us all. So our next presenter is the President and CEO at the Alliance for Aging Research, the leading national nonprofit organization dedicated to accelerating the pace of scientific discoveries and their application to improve the experience of aging and health. Since 2012, she has been a driving force in the growth and success of the organization. As a thought leader on many aging-related issues, she's led the Alliance in efforts to boost older adult immunization rates, increase NIH Alzheimer's disease and aging research funding, raise awareness of geriatric cardiac issues, reform Medicare treatment access issues, and most importantly, address cost of care issues and value frameworks. So I would like to welcome Sue Paschen. Sue, thanks so much for being with us.
Thank you, Debbie, and thanks to Randy and Bio New Jersey for hosting this great webinar. It's just a pleasure to be on with Bill and Terry, and really appreciate you all covering this important topic. So next slide. So Bill spoke a bit about QALYs and their impact on age, and he gave a great hat tip to Captain and Tennille, which I loved. So who doesn't remember love will keep us together, right? But I'm going to dive a little further into the details of how they discriminate when it comes to measuring cost effectiveness of interventions, specifically for older people. So overall, QALY is based on the premise that an older person living with a disease or a person of any age living with a disability is economically worth less than a younger or healthier patient, simply because the older we are, the less or the more disabled we are, the less calculated life years ahead we're considered to still have. So this gets clearer when you look at an example like Alzheimer's disease. The majority of people with Alzheimer's disease are really what we consider the oldest old. And if you look at the charts on the right from the Alzheimer's Association, you can see that of the estimated 5.8 million people with Alzheimer's who are age 65 or older, about 80% are 75 or older, and more than a third are 85 or older. And also, people with Alzheimer's disease often have additional conditions. About 1 in 5 to 1 in 3 have conditions like congestive heart failure, chronic kidney disease, diabetes, and coronary artery disease. So this doesn't make you very valuable in the world of QALYs. QALY models also don't recognize the burden of Alzheimer's disease on family caregivers and society. So the cost effectiveness calculation doesn't recognize the value of treatments when they can help alleviate that burden. Anything that's unrelated to health doesn't really count. Additionally, Alzheimer's disease is usually accompanied by neuropsychiatric symptoms such as psychosis, agitation, depression. So along with disease modifiers, there are treatments in the clinical pipeline to address these types of symptoms. But QALYs don't value symptomatics that may only improve quality of life, but not length of life, as valuable as disease-modifying treatments. And so this applies to a lot of clinical areas like pain treatments, mental health treatments. So there's whole areas that are just considered not as important, not as valuable, because they don't lengthen life. Also, the traditional model considers current productivity in its estimation of value. So if you've had a lifetime of previous productivity, that doesn't count, nor does any kind of productivity that's not economic in value. So cost effectiveness that relies on QALYs, which is what ICER uses, becomes a real treatment access issue in the Medicare program. Federal law under the Americans with Disabilities Act that Bill referred to bars the use of QALYs from coverage decisions in Medicare, but it doesn't limit their use by private Part D plans for formulary decisions and utilization tools like step therapy and prior authorization. Next slide. So to Terry's point, we wanted to actually get some numbers behind, do people really understand what this is about and what's going on here? So we commissioned a survey by the Engine Group between April and May, just within the last couple of months. We surveyed 1,000 people, and we asked a few questions regarding public perception of healthcare rationing. And amid the coronavirus, healthcare rationing has become a real concern, especially you've heard a lot about it around ventilator access and hospital admissions. And we wanted to know whether people in the United States were aware that rationing was being encouraged by ICER. So in this survey, we asked participants if they were aware that there's an organization funded by health insurance companies and foundations that makes recommendations about which drugs and medical treatments should be or shouldn't be covered by insurance. And the majority, 58%, said they were not aware. And if you look at folks who are on the older side, 55 or older, 72% were unaware. We also asked if people believed health insurance companies should be able to deny coverage for medical treatment based on age, illness, or disability. And an overwhelming 70% strongly disagreed. And then last, we kind of dug into something that's been considered by both HHS and the House of Representatives and some of the drug pricing debates about whether or not the United States should follow the lead of other European countries that use a similar methodology to ICER for limiting access to healthcare. And 57% of overall respondents said no, and 73 over the age of 55 said no. So overall, awareness of ICER itself and its methodology is pretty low, and it's kind of designed that way. Next slide. So we started a campaign in late 2018. I know groups like Terry have been at this much longer than we have, and we look to them and their lead on this, as well as the people with disabilities community who have really been out there. But there wasn't really a campaign around educating policymakers and older adults about ICER and really focusing on the use of QALYs and the impacts on access. We don't tackle ICER's individual drug reports, but we look at the broader messages around the methodology. We have an ICERfacts.org webpage that folks can check out, and we have a consumer-friendly video on QALYs that can be downloaded. And people can sign up if they want to stay engaged at the individual level. And we have a lot of people now in the thousands signed up from across the country. We've done several opinion pieces connected to national conferences of governors and state legislators. And most recently, Oklahoma enacted the nation's first QALY ban. It's called the Non-Discrimination in Healthcare Coverage Act. And it prohibits Oklahoma government from discounting the value of a person's life because of an individual's disability, age, or chronic illness. And it's in regard to decision-making about which healthcare services are going to be covered by a government health reimbursement plan. So that includes the state Medicaid program, incentive programs, and utilization management decisions. So it's really exciting. And I think that many of you may have seen a piece that we had in the Oklahoman on this to praise the action, because, you know, when these things happen, you've got to jump on it and say, go team. And we want to, you know, we definitely want to see more. So next slide. So what are we encouraging the health economist community to consider as alternatives to QALY? Well, I was lucky to recently be able to present at ISPOR, which is the leading international professional society for health economists and outcomes researchers. And it was really interesting because I think as a community, they're starting to reflect, given the coronavirus pandemic, on, you know, what are we doing with the QALY? And considering that older adults and people with the underlying conditions are so disproportionately impacted, they tend to be sicker, the mortality rates are higher, it's really making folks be much more introspective. And I found that fascinating. If you think about health economics, it's really the only area of economics that doesn't integrate behavioral economics. Health economics looks at folks at the population level, but behavioral economics adds the perspective of those that are actually living with a particular disease or condition, instead of only healthy consumers or economists who are merely contemplating what living with a certain disease might be like, and then making assumptions about what matters to those who have the disease or the condition. Because we change as we get older, we change when we develop a condition. Something that might seem horrible to us as a younger, healthier person, if we're dealing with it and, you know, it comes our way, we adjust. And, you know, and that's what behavioral economics is about, is accounting for those adjustments. But standard health economics and the QALY, they don't really account for that. So we also need to find ways to consider economic value from treatments that improve the patient experience, and then how that extends to family caregivers in the community. And we also advocate for models that place emphasis on the value of the medical product itself, that base value on the outcomes those products provide that means something to the patients that are going to be using them. We would rather see those types of outcomes be monetized than the actual individual be monetized. And we do it with all other types of consumer products, our cars, our homes, pretty much everything else. And an example of this would be value-based contracts, which I'm sure a lot of you have heard of, except we'd like to see more integration of patient-reported outcomes and patient preferences on health outcomes and related to risk-benefit. And those haven't been integrated as much in the value-based contract, so we want to see a shift there. Next slide. And if there's an interest in developing alternative models, we really feel like it's important to have all stakeholders at the table, because, you know, it's going to vary significantly depending on who you have, and that's going to be a reflection of who was involved. Now, there's been a focus in the last year or two on drug pricing in particular, and I think measuring value in a different way requires a broader lens that considers total costs of care. Bill referred to this a bit, including the tremendous out-of-pocket costs that families pay for many of the conditions that they experience. And also, the list and the launch prices of drugs are not what patients usually end up paying. And that's what ICER talks about when they talk about the price. And that says nothing about the cuts that are taken by PBMs and payers in the still sort of hidden, mysterious world of rebates and formulary negotiations. And those, we feel, really need sunlight. In the ICER remdesivir COVID-19 treatment dialogue, one thing that we've been hearing a lot is, well, NIH invests, so therefore, you know, that should be considered in the price, and, you know, really should cost basically nothing. And I want to debunk that canard by showing the breakdown. This is something Research America puts out every year. and to take a look at the total research investment of industry compared to federal healthcare spending. And it really varies quite a bit, 22 to 66%. And I think that's important for us to point out. Next slide. My last points speak to the broader implications of how we approach value. There's a Nobel Prize-winning economist named Milton Friedman, who a lot of health economists look up to and refer to. And his edict is that patients and clinicians won't ever economize on care, and that patients have no buy-in, that we basically treat it like we're walking into a store, I'll take one of those and one of those, even though really we just want to get better, we want to feel better. We don't know, right, what costs this or that until we're done. So that's not really the real world story. And buy-in to healthcare coverage is happening. People who are older have paid into plans in the Medicare program for decades. And for others who don't qualify for Medicaid but teeter just above, trend-wise, they're seeing rises in higher premium and higher deductible plans. Old and young are seeing more out-of-pocket costs. And the middle are seeing higher taxes with not a lot of income increases, not to mention all the job losses that we now have going on. So our collective value, except for the most wealthy, is actually getting less each year. So we have to sort of face this question about what is our duty to each other, especially to those who may no longer add economic contribution to society the way we traditionally measure value. Are we really sort of saying to them, too bad? Because I don't think that's what we mean to say. So I think we need to challenge ourselves to have more vision and think about what's going to make our society healthier and better in a more holistic way. This is not to say let's pay for everything and everyone recklessly. This requires looking honestly at how we've designed our research and healthcare ecosystem, soup to nuts, and to figure out how to fix it in real ways. So that's my presentation. Thanks so much. My last slide is our contact information.
Great. Thank you so much, Sue. Very much appreciate it. And also, again, thank you to Bill and Terry. We will move into our Q&A now, and I'd like to remind you that you can submit questions for our panelists by typing in the box on your computer screen. We do have a couple of questions, so we'll go right into them. Actually, this question is specifically for Bill. So Bill, could you please elaborate on how a therapy that costs $500,000 over 2 years, let's say, translates into individual insurance bills and the role that insurance companies play in pricing such therapies for rare diseases?
Okay, well, thank you for the question. I'm not exactly sure of what the questioner is trying to get at. Just on as far as commercial health insurance companies and expensive rare disease drugs, I sort of agree with Sue that because of the trend towards more expensive rare disease drugs, the healthcare system's got to move more and more towards value-based contracts. So if you have a gene therapy that's going to cost $800,000 and it promises to cure a patient and extend their life for a long period of time, that the payments should be spread out and there should be certain benchmarks that have to be met. Now, there are complicated practical problems when you do something like that. What if the patient changes insurance? Who makes the payment when the patient gets to a new insurance company? And there are think tanks at MIT and Duke and other places working on this. And I do agree with Sue, there should be patient input into some of these value-based contracts. But I think if we're going to go towards six-figure drugs, that in fairness to payers, there has to be some standard of quality and value and benchmarks along the way that have to be met before these payments can be finally made. So I think I'd just leave it at that.
Terrific. Thank you, Bill. Thank you. So this question is coming in not specifically addressed to any panelists, so I welcome all three of you to consider taking a stab at it. So what is the role of clinical trial design in addressing some of these issues? As an example, if quality of life issues are included in clinical trials and FDA approved labels, would ICER be forced to include these considerations? Anyone?
That's a very good question. I mean, that's a great question. What FDA uses in terms of their approval and then what happens on the coverage and reimbursement side really are quite separate. So even if, something improves symptoms, which is what you might be referring to, or function for that matter, in the label from an FDA perspective, it's really kind of the same recipe at ICER regardless of what FDA has approved a drug for. So it doesn't really enter into that. But that's it's an interesting argument to make.
Thank you, Sue. Anyone else? Terry or Bill?
Yes, this is Terry. I would touch on that to parrot somewhat what Sue is saying here. ICER isn't a government regulated body, so they're not required to include or not include anything really. So whatever you do, you would hope that they would include those measurements or however the clinical trial is designed. But I mean, as many people and many folks in the industry that I've talked to about their engagement with ICER, I had a call just the other day. It was like, we gave them all this other evidence and we had all this, we presented much more and they just ignored all of it. And patient groups just said the same thing. So I don't really know how ICER goes about. It's very arbitrary in many ways, just from where we sit, having followed them. So I don't think they would be required to include anything.
Yeah, I would just add to what Terry said that companies have to make their own decisions about how they're going to adjust themselves to ICER, whether to deal with ICER, whether to not to deal with ICER. And I don't prejudge or second guess those decisions. It's all based on the product and the patient mix and competing products, and they have to make decisions about what their strategy is regarding ICER. But I would just say that they should keep top of mind that ICER's goal and its mission is to reduce drug costs. That's their stated goal. And so you should just keep that top of mind when you think about making adjustments to conform to the ICER methodology.
Great, thank you. Thank you all on that one. Another question. So I don't believe the ICER methodology accounts for the downstream cost savings in the health system from innovation. Can you please comment on this? Anyone?
Yeah, this is Bill.
Go ahead, Bill.
No, go ahead.
I was just going to say, yeah, I mean, the questioner is absolutely correct. It's sort of looking at the immediate, what is the impact on the patient? What is the outcome of the therapy compared to existing therapies? And it's a very tunnel vision type of model. So broader issues on those downstream costs and impacts on society, impacts on family and caregivers, those are not considered.
Yeah, and I was going to add that there are some economists, I think his name is Kevin Murphy from Chicago, who have done some studies that argue that given an unbelievable advances in longevity that drug therapies have created over the past 50 years. I mean, people were dying in their 50s not too long ago, and now they're living to their 80s. The amount of economic growth that has created to have productive citizens living 30 or 40 more years has far dwarfed the costs associated with their care. You're having people in their 50s that are extremely productive, making the height of their income that they've ever had, that 50 years ago may not have even been alive. And so ICER's methodology doesn't consider factors like this, that the value of older Americans in the economy is enormous and actually may dwarf their healthcare costs.
Okay, thank you. So let's see, as we heard, Oklahoma became the first state to ban the QALY in decision-making about which healthcare services will be covered by a government health reimbursement plan, including state Medicaid programs, incentive programs, utilization management decisions. So it's a two-part question. Do you think that other states may follow? And what's your thought on whether a federal ban on QALYs is needed? And what would that mean to the federal health programs?
So I do think that there's a great opportunity for other states to follow. I think Oklahoma set an awesome example. I will say ICER is pretty active at the state level. So part of the reason why I was so thrilled to be convening with Bio New Jersey today is, you know, as a state group, it is really important. I'm sure all the companies that are on the line look to your state association to follow these issues. And there will be opportunities in the coming months to consider these types of policy alternatives. And I hope you all come out in support of it. I think there's a real chance of success. And once we get a few under our belt, along with the patient advocacy community, the people with disabilities community, we'll have something to really point to and say, this is what's happening in the states. We need to reevaluate groups like ICER for application at the VA by PBMs across the board like CVS. What's going on there if states are responding in a different way. And then at the federal level, I think there's also opportunity there. We need a universal ban. There are some federal laws that have been interpreted, Americans with Disabilities Act, the Rehabilitation Act, and there's a couple of provisions in the Affordable Care Act that limit discrimination by use of cost effectiveness measures like the QALY. But they're sort of limited to coverage decisions. And so the use of them for formularies and utilization management, that's all still around. We need a universal QALY ban. And I think just like the health economist community is kind of looking at why have we been doing things this way, Congress needs to do the same. And, you know, but we have an educational hurdle to overcome. And as many groups that are as willing to sort of join together to educate and push forward with something like this, I think we'll be able to be successful.
Yes, and I would piggyback on what you just said as far as, you know, educating in order to pass more in the states as well as at the federal level. It's educating the patients, the patient stories, because as I always like to say, you can go in and talk to legislators and representatives all day long. We as advocates can do that, but there's nothing more powerful than educating and activating the actual patients to tell those stories. Because when you walk in there and ask for something, you need to be telling them what to do. They hear from everyone from, you know, who wants to save the smeltfish to like who wants to ban ICER QALYs. I mean, all day long. And so when you're looking at these things, it's really important to educate your ground team, your patients, and your advocates and your caregivers, and really make sure that they are going in armed with their own personal connection to why this is important. In this instance, it's not that hard because it is that important.
Great. Thank you. One more question. I think we have just another minute for this last question. So if someone wants to take a stab at it quickly, that'd be great. So how will the ICER methodology likely be applied to COVID-19 vaccines? An important and timely one. Anyone?
Well, I would jump in and say no matter what the price is, ICER will say it's too expensive. That's my only comment.
Okay.
Yeah. The only thing I'll add, Debbie, is with regard to vaccines, it's a little bit of a different animal, and there's a Dole by Act. I mean, there will be kind of different calculations made there, and I think ICER is going to have a really hard time trying to insert itself. That's why I think they're trying to get in on the treatment side. Because the vaccine side, I think, is going to be a lot more challenging for them. There's going to be a lot of consensus around people need this. The companies have a big spotlight on them. I think it's going to be much easier to build consensus around pricing of vaccines.
Great. So thank you all so much to our panelists, Bill and Terry and Sue, for sharing your time, your expertise, and your support. Thank you all to the audience for engaging with us, for being here and asking some really smart questions. A reminder, a recording of the webinar will be available on the BioNJ website tomorrow at bionj.org. Also, we invite you to take a look at bionj.org/innovation. You can join us there in this conversation. You can sign up to receive informational tools and resources on a regular basis on this topic. Again, I'd like to thank you all for joining us today. I hope that you thought it was informative. Please contact Kim Minton on our team if you'd like to learn more about BioNJ. Also, like to invite you all to participate in a webinar on Friday, June 5th, where we'll be talking about the amazing research that's going on globally on COVID-19, and then highlighting 10 New Jersey companies that are working on it. And then on June 16th, we'll do it again with an additional 15 companies, including some from around the world. So thank you all for being with us. Please stay safe and healthy, and we'll see you again soon.